All right. So, what question was that? We were talking about the SIMV. It's not page 1124. I'm still with what edition is this? With the 10th edition. So my page numbers are slightly off. So 1084 is more where you can find that information for you guys. 1084 about the SIMV. Y'all all right?
Yes, my phone decided to go crazy.
Oh. Yes. For chapter 48, look at table 48-2 specifically, and it tells you about patients tending not to hyperventilate so much when they're in the SIMV mode. All right. Okay, let's go. All right, okay, got some more questions for you. All right, so here we go. This one is about non-invasive ventilation. And this is regarding the most important advantage over of NIV over other types of ventilation. So what do you think is the most important advantage of NIV over using other types of ventilators? What's the advantage of going to NIV? What's the most important advantage? There are several, but what's the most important?
Avoid intubation.
Patient can spontaneously breathe.
That's an advantage if they're weaning, yes. But something more regarding how the NIV works. This was actually another question on your study guide.
Is it decrease in the intubation rate, decrease in mortality rate, and number of infectious complications?
No, I need more of how the NIV works. NIV itself works. So how does NIV work that makes it better to use on some patients over other types of ventilators? How does NIV work? What is it that you know that the BiPAP? How does the BiPAP work without even worrying about the other ventilators? How does BiPAP? Got an IPAP, EPAP. How does it deliver the pressure? How does it work?
Mechanically ventilate the patient by the means of not endotracheal tube, but a full face mask or
right. So non-invasively, meaning you're not having to insert each tube, artificial airway. Okay. What else? What about how the pressure is delivered? Is it a patient-triggered situation? Yes. So patient trigger and cycle. And then what about the circuit and the mask, the interface? We're talking about that mask. What's special about the circuit and the mask that's different from mechanical ventilation?
A small leak is required.
There you go. Right.
The patient can manipulate the size of the breath.
Okay, what he said. He said small leak.
Can you repeat that, AJ?
A small leak is required to work properly.
Small leak. So you need a leak with NIV. You can't have a leak with your mechanical ventilation in order to hold your volumes and pressures. It won't work. With your NIV, you can trigger and cycle your patient's breaths with the small to moderate ear leak. Okay. All right. So for NIV, you have several different alarms. You have several different types of alarms. Is the loss of power one of those alarms?
Yes.
Yes. Circuit disconnect, is that one of your alarms?
Yes.
Yes.
Okay. Battery failure, would that be one?
Yes.
Yes. The blender alarm.
No.
No. The blender actually, if you did decide to set up a blender, which you could do, if you're trying to set up extra oxygenation, you could do that. But the blender has its own alarm, so it's not a part of the NIV alarm system. All right. So when you are setting a patient up on PEEP, if you're adding PEEP, how much is necessary to prevent rebreathing of CO2? How much PEEP is necessary to prevent rebreathing of CO2?
3 to 5 centimeters of water pressure.
That is correct. Yes. All right, let's go. All right. When you are using NIV, you have a patient who is on NIV, a patient who you're thinking of putting on the NIV. What would be some predictions or some successful predictions for the use of NIV? Okay, so would low severity of illness be a good indicator that your patient would be successful on NIV?
Yeah.
Yes, because if you're really critically ill, you should be on mechanical ventilation, not NIV. So low severity of illness would be a good predictor. What about improvement in gas exchange within 30 minutes?
Yeah.
That'd be a good, yeah. So definitely, because what did it say? If you need to wait at least an hour, 1 to 2 hours. So if you improve your gas exchange improves within 30 minutes, you're doing pretty good. So yes, that's a good predictor that you're going to do well on the NIV. What about minimal air leak? Yes.
Yes, because it helps.
Yeah, huge air leak is not good. So it does work with the leak in the system, but if the leak is too big, then it's going to be a problem. So minimal air leak, low severity of illness, improvement in the gas exchange within 30 minutes. Those are all good predictors of success on NIV. Great. All right, so this question here, you might remember this from, I couldn't even tell you which one, but this was one of your questions before in your study guides, talking about restrictive thoracic diseases with NIV, okay? So what restrictive diseases are managed with NIV? Would that be severe kyphoscoliosis?
Yes.
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 That is post-polio syndrome?
Yes.
Yes. Spinal cord injuries?
Yes.
Neuromuscular disease?
Yes.
Yes, so all of those are successfully managed with NIV. Correct. And speaking of NIV, your patients who have COPD, what should be considered the first line of therapy for your patients with who have COPD? What should be considered as the first line of therapy for them as far as helping them breathe? Would you say mechanical ventilation would be first? Would you say a high flow nasal cannula would be first? Would you say go to systemic steroids? Would you say NIV?
NIV.
NIV, because it's harder for them to
NIV, yeah. Yes, so NIV. Now, here's the thing, because patient with COPD can go to mechanical ventilation. He can use a high flow nasal cannula, and he or she can use steroids, depending upon what else they have going on. So all of those can be, used with COPDers. It's just a matter of the question saying what's the first line. So NIV would be your first line of therapy, and then those other ones can come based on what's next, what's needed. Okay. When you're talking about mechanical ventilation, what vent setting is good for pressure triggering? What setting on a ventilator is good for pressure trigger? Pressure triggering, good Lord. What trigger level is appropriate for pressure triggering on a ventilator?
Is it 1 to 2?
Below
1 to 2?
1/2 to 1.5, and if it's changed, I've got 1/2 to 1.5 below baseline. Are you seeing in your book where it says 1 to 2?
Yeah, I think that was 1 to 2.
That doesn't sound familiar too. I don't know why it says 1/2 here. Yeah, it does say 1 to 2. Oh, I see. On page 1086, on 1086, it's the unit. So if we're talking about centimeters of water, so on that second column, 1086, the second column where it says with flow triggering, the trigger should be set at 1 to 2 liters per minute, and with pressure triggering, the range is -0.5 to 1.5 centimeters of water. So just look at the unit. So we're talking about triggering with pressure trigger. So pressure triggering is 1/2 to 1.5 centimeters below baseline. Okay. All right, so for adults with fairly decent lungs who are receiving vent support, what IE ratio should be your target?
1 is to 2.
1 to 2, 1 to 3.
1 to 2, right? Correct. 1 to 2, and that's in pretty much any mode. So I could throw out assist control mode. You're still going to target 1 to 2. I can throw out SIMV, well, not SIMV, but full control mode. You're still going to stay 1 to 2. So any control type mode, your target would be 1 to 2, unless they have some other issues going on. Okay, all right, so flow. If we are contemplating using flow, and we're talking high inspiratory flow with COPDers. So if we're contemplating using high flow with our COPDers, tell me what types of benefits would high flow give to our COPDers? What types of benefits would be included for COPDers? What's the benefit of high flow?
The benefit of high flow is you give them more flow so they can have more, so they can expire more. I mean, if you give them a higher flow, then it's better for them to expire.
So you're saying increased flow decreases the I time, so it increases the E time? Is that what you're saying?
Reduces dead space.
Yeah.
No, that's what I'm saying. Say it. That's what I want you to say. Say it. Yes. So,
Okay.
all right. So what else?
It decreases the air trapping.
Okay. Pink Drink said something first.
I was saying just reduce the dead space.
Okay. Reduce dead space. And that can go along with improves gas exchange. So yes. Okay. So that'll go along with that. Improves gas exchange. What'd you say, Flo?
It just I forgot what I was saying. Oh, decreases air trapping.
Okay. Well, that's part of what you just said with the E time. So if you extend their E time, that decreases their air trapping. So yes, right. Which also goes along with decreasing auto peak. So all of that is saying the same thing. So increasing the flow allows for that longer E time, that decreases air trapping, it decreases auto peak, right? So all that's the same thing. And then work of breathing. Does it increase or decrease their work of breathing? Decreases, right. Decreases their work of breathing. So all of those would be benefits for high flow. All right, so on some of your ventilators, what can happen if your trigger setting is set too sensitive? What can happen?
Auto triggering.
Auto triggering, which means what?
The machine will keep going and triggering to turn on.
Give me more.
Instead of
The machine will be triggered easily.
So what happens to your patient? Tell me more than just the machine. So the machine triggers, which means what? What happens with your patient?
they have to keep taking a breath. They don't have time to.
They have to take a breath. Who said that?
I did. Breath.
Yeah. So triggering means that now it's initiating another breath. So it's making your patient do that. So auto triggering, and you'll see the waveform do that too. So you'll know when you have auto triggering going on because you'll see the waveform just speed up real quick, and it's just deep and fast, up and down, and you'll see your patient's chest rise too going as well. So auto triggering is bad because now you're making your patient hyperventilate, really, right? And then of course that can induce auto trapping as well. So,
and that's
that you decrease auto triggering. Yes, ma'am.
That's the same as breath stacking, correct?
Right. That is breath stacking. Yeah, and that's why SIMV is great because it helps to eliminate some of that. Right. Pressure control. Excuse me. When is pressure control most often used? I'll give you some options. Is it used more when a pneumo is present? Is it used more when the patient has COPD? Is it used more when you're limiting plateau pressure? Is it used more when bilateral pneumonia is present? Which one of those?
With pneumo.
I hear a pneumo. Okay.
What was the last one you said?
When bilateral pneumonia is present.
I say pneumo.
Pneumonia. Okay. I've got pneumo and pneumonia.
You said pneumonia. You said bilateral pneumonia, a pneumo, and what were the other ones?
COPD, and then when limiting your plateau is needed.
I wasn't.
Okay, you want to change
Limiting plateau.
Isn't it
The
limit?
limit plateau.
Limiting
I mean,
plateau.
Why? Why do you want to change to that?
because that's the answer.
Because you're controlling pressure, and that has to do with pressure. Your plateau pressure is has to do with pressure. That's your pressure when the person is taking a breath. So you want to control that.
Okay, yes. Somebody can add some more thoughts to that. Because when you switch to pressure control, your problem is increased pressures, right? So if you're in volume control, the reason you go to pressure control is because the pressures are getting too high. They're getting out of hand and unmanageable. So you want to go to a mode where you can manage the pressures more. So that means your peak pressures are high, your mean airway pressures are high, your compliance definitely is going crazy because your plateau pressure, and it's really plateau more so than dynamic compliance. You're looking for that more so than that. So your plateau pressure is very important. So when you do that calculation, you don't want to forget or overlook the plateau. So calculate that plateau to see what's going on in the airway. So if your plateau pressure is getting way too high, definitely a reason why you want to switch to pressure control. Okay. What's the problem or one of the disadvantages of going to pressure control? So an advantage is that you can manage and control and limit the amount of pressure being applied to the airway, but what's a disadvantage?
You can't manage the volume.
You can't control the volume, right? So because the volume will vary, right? In pressure control, your volume varies, your rate can vary, and now your patient does not have a guaranteed minute ventilation. So that can be an issue with pressure control, and that's the reason why we don't go to pressure control first, because there's issue with giving your patient volume and they're not ventilated properly. So yes, pressure control is very good for limiting that pressure. With ARDS patients, any patient that has that increased pressure issue, but then you have the issue of volume being not guaranteed. All right, okay, very good. Yes. All right. All right, so what mode, well, there are lots of modes, but when you're managing, well, let's ask it that way. Okay, so if you have a patient who is needing NIV, all right, there are some different reasons why you would use NIV, such as the use of COPD. So we already mentioned COPD. True or false, NIV can also be used to manage cardiogenic pulmonary edema. True. Yeah, because we said that in another answer. So that is true. NIV can be used to manage premature extubation.
True. True.
Yes, because we can use it for weaning.
Yeah. So we'll say yes to that. How about management of ARDS?
False.
No.
Thank you. Quickly say no with that one. Yes.
No.
Absolutely no. Yes. So ARDS, no for that. Okay. So yes to COPD, yes to managing a premature extubation, management of cardiogenic pulmonary edema. Right, so clinically speaking, there's some clinical objectives for vent support. That would include to reverse hypoxemia. Okay, so we already know that. What are some other objectives for vent support besides to reverse hypoxemia?
To prevent or reverse atelectasis.
Yes. Give me another one.
To reverse ventilator muscle dysfunction.
Okay, yes. Give me another one.
To reduce ICP.
No, okay, yeah, that one, yes. I'm looking for an acid-base balance. What is it that it's usually used to reverse?
Acute respiratory acidosis.
Yes, absolutely. Tell everybody where you found that.
Number 8 on exam 2 study guide.
Okay, and we're in the book. Do you have page number?
Safety and Egan, box 48-2.
Yes. So those are your clinical objectives of vent support. All right. Speaking of modes of support, what mode would you recommend for a patient who can breathe spontaneously and only requires assistance to overcome the work of breathing created by the ET tube?
Pressure support.
That would be correct. That would be. If you're in the volume control mode, what's your initial volume, tidal volume that you're going to set? What's the recommended range for setting tidal volume?
On which mode? I'm sorry.
Volume control.
6 to 8.
6 to 8. 6 to 8 what?
Milliliter per kilogram.
Milliliters per kilogram, correct.
Mm-hmm.
All right. Okay. What situation would call for vent settings of low volume and high rate and this would allow permissive hypercapnia?
ARDS.
That is correct. All right. When you get your order for vent settings, tell me what should be included with that order.
The rate, the mode, rate, PEEP, tidal volume, or pressure.
Yes, and PEEP if they're on it. So PEEP may not always be in the order, but if they're on it, yes. Okay. Yes, very good. Would flow be in the order?
No.
No, doctor does not tell you how much flow. How about sensitivity? Would that be? No, doctor's not going to tell you how much sensitivity that's for you to do. What about the trigger level on the vent?
No.
No, those are for you. Those are for you to put your nice hands on and titrate to whatever your patient's best outcome would be. Okay, if you have a patient who is on mechanical ventilation, and you see that their tidal volume is pretty high. Okay, so their tidal volume is about maybe 11 milliliters per kilogram. And then you see that their plateau pressure is high, about 50 centimeters of water. What would be your next action to recommend to a physician? What would you recommend to the doctor?
So lower the tidal volume?
Yes. So we're going to lower that tidal volume. Yes, because tidal volume directly related to increased pressures. So, and then we already know the recommended tidal volume is 6 to 8. So if your tidal volume is at 11 milliliters per kilogram, you already know that that's the reason why the pressures are too high. So where should we keep our plateau pressure?
Below 28.
Below 28, right. 28 or below is good. right, so what are some hazards of mechanical ventilation? What are some problems that can occur when dealing with mechanical ventilations?
Ventilator-induced lung injury,
Absolutely, yes. What else?
ventilator-associated pneumonia,
Yes.
decreased venous return and cardiac output.
Yes, absolutely. And this is weird. Also increased work of breathing is in that list of things that can happen with mechanical ventilation. So, and that comes from patients being in that control mode, and we're causing them to breathe more than the non-control mode, where patients are doing more work, and that can cause increased work breathing for them in that respect, which is not always bad. Sometimes we want them to have increased work breathing because we want their muscles to get used to the spontaneous breathing so we can wean them. Sometimes it can be bad if they are not ready to wean, and now they have all this increased work of breathing. So it just depends on your patient. So mechanical ventilation can cause increased work of breathing. It just depends on what's going on with the patient, whether it's good or bad. All right, tell me an advantage of pressure control ventilation. I thought that was thunder. Yeah, thunder. Big time over here.
It's starting to rain over here, Ryan.
Yes.
All right, it's thunder.
Yeah, it's thundering over here. All right, so pressure control, what's an advantage? What are some advantages of pressure control ventilation? We kind of mentioned a little while ago.
Variable flow results in square pressure waveform and improves gas distribution.
And the improved gas distribution allows for what kind of tidal volume?
Lower tidal volume.
Lower, there you go, for a lower tidal volume. Correct, yeah. Improved gas distribution, and then that helps for that lower tidal volume for patients who have excessive pressures. That's their issue. They have that high pressures, a high tidal volume, so helping when they get into pressure control, then that can lower, but then that can backfire, so you have to be very mindful and watchful on the tidal volume, correct, because it can lower it way too much. All right, so for patients with ARDS, what's the recommended tidal volume?
4 to
6. 4 to 6. What's the unit?
Milliliters, 46 milliliters per kilogram.
Yes, okay. All right, so if you are in a pressure targeted mode of vent support, what things would the volume depend on? The volume delivered to the patient will depend on a few things. What are those things? In a pressure targeted mode of vent support, the volume delivered to your patient depends on several things. What are those things? What's that? Flow? I'm hearing something, but I can't quite make it out. Would it depend on the patient's lung mechanics?
Yes.
Yes, it would. How about the pressure, set pressure limit?
Yes.
Yeah, it would. What about the patient's effort?
Yes.
Yes, it would depend on all of those things because you're in that pressure targeted mode. Okay, so if you are looking at recruitment, and when we're talking about recruitment, we're talking about PEEP, setting PEEP and trying to recruit to more alveoli to open up life. So if you're trying to do a recruitment maneuver, there are some settings that you need to make sure that you're aware of. They're called safe settings. So what kind of pressures can you go up to? What's a safe pressure limit that you can go up to when you're setting your pressure? How high can you go? Up to what? I think, Nicole, you answered this question before. Recruitment. If you're
The 30 centimeters water pressure?
you can go higher. Yes, you can go higher. Yep.
Would it be 35 to 50 centimeters water pressure for PIP?
So you can go up to
50.
50, right. So you can go up to 50 centimeters of water. How long can you apply the pressure?
1 to 3 minutes.
1 to 3 minutes. Yeah, tell everybody where you found that.
Number 13, exam 1 study guide.
Okay. And where in the book?
1029 in Egan.
Alrighty. Questions? All right, so if you're talking about work of breathing, the magnitude of work of breathing would depend on some things, and these are about 5 different things that the magnitude of work of breathing would depend on. What are those things?
Compliance, resistance, force drive, trigger sensitivity, and peak flow.
Very good, very good. Where did you find that? Tell everybody where you found that.
Number 14 on same study guide and page 1030 in Egan.
Okie dokie. Very good.
I'm sorry, what did you say that was?
Number 14 on exam 1 study guide or page 1030 in Egan.
All right. Okay. I'm going to give you a few situations. You're going to tell me which one of these situations would be the least cause of acute respiratory failure needing mechanical ventilation. Okay? Which one of these would be the least cause of acute respiratory failure needing mechanical ventilation? All right. Heart failure, aspiration, post-op respiratory failure, and sepsis. So heart failure, aspiration, post-op respiratory failure, and sepsis. Which one of those would be the least cause for needing mechanical ventilation? Actually, what's that? Which one? Sepsis? Post-op respiratory failure? Heart failure? Aspiration?
I think sepsis.
Sepsis?
I'm gonna go with sepsis. Well,
Another one for sepsis?
yeah.
Interesting.
Sorry, what was the question? The least cause? Or
Mm-hmm.
for
Yep, the
mechanical?
least cause for needing mechanical ventilation.
I don't think it would be sepsis. What are the other questions? What are the other answers?
All right, hang on a second. Okay, I'm back. Okay, sorry. What was your question?
I was wondering the other options other than sepsis.
Pulsed respiratory failure, heart failure, and aspiration. So which one of those? I heard 2 for sepsis. And actually, sepsis is actually high on the list.
Yeah.
For mechanical ventilation.
For ARDS.
Yeah.
Yeah, so sepsis is high on the list.
I think aspiration, maybe?
What's that?
Aspiration? Because aspiration can lead to, but I don't know if it's the right way.
Correct.
Yeah.
Page 979 has a list of your causes of respiratory failure. Aspiration is like way down there on the bottom of the list, and it has they've got increased exposure, and aspiration doesn't have that much exposure for it. So aspiration is the least cause. Okay. So now aspiration sometimes does need to, have a patient go to mechanical ventilation, but
not right away.
Often, that wouldn't be the most from that list of other issues.
And what page was that? I'm sorry, you said
979. It's in the box, table 44-2. All right. Okay. So explain why metabolic alkalosis does not require a high mechanical respiratory rate. Explain why a patient who is in metabolic alkalosis does not require a high mechanical respiratory rate. Explain.
Sorry, can you repeat the question?
Metabolic alkalosis.
Uh-huh.
And explain why, if you have a mechanically ventilated patient who has metabolic alkalosis, explain why you would not need to set a high respiratory rate on the vent. So ARDS patients, you need low volume, high rate. So they would need a high rate. If it was metabolic acidosis, you would need a high rate for them, right? Because you need that increased rate to kind of normalize the pH, get the pH to come back up. So they need a high rate. So with increased ICP, you need high rate to blow off some of that CO2 for that, to decrease some of the pressure in the brain. So ARDS, ICP, your patients with metabolic acidosis, all of those folks need high rates. Why would a patient in metabolic alkalosis not need a high rate?
Are they already at a high rate?
Well,
Are you asking me or are you telling me?
I'm trying to think.
Tell me.
Well, the response to metabolic alkalosis is hypoventilation.
So I'm asking about metabolic alkalosis. Is that what you're answering?
Yes.
Okay. Yes. So set up the blood gas. So the metabolic alkalosis, what kind of pH do you have?
High.
We got a high pH, right? Because it's alkaline. So it's metabolic. So that means we go to the bicarb. What kind of bicarb do you have?
High.
High as well. So that means the lungs are going to be the buffer, right? So in order for the lungs now to get that, to help get the pH to come down, what is the CO2 needing to do?
Increase.
Decrease.
Say it again.
CO2 needs a decrease, right?
Decrease. So you need that decrease the rate to normalize the pH. So with that metabolic alkalosis, you're not needing the high rate, you're actually needing the opposite. So your acidosis, you need the high rate, but in alkalosis, it's the flip side of it. So acidosis, you need the high rate, but in metabolic alkalosis, you need the decreased rate to kind of normalize that pH. So that's why with metabolic alkalosis, it does not require the high mechanical high mechanical rate, because you need a decreased rate. You need to lower that rate in order to get that pH to come down. That's how the pH works. pH and CO2 don't work together. They're kind of opposite of each other. So if you have a high CO2 and a high pH, well, the pH is going to go in the opposite direction of your CO2. So if your CO2 is high, then the pH is going to come down. So that's what you need with a metabolic alkalosis. You want the pH, the CO2 to be to get that CO2, the pH to come down. So in that event, you're not needing that high rate. You're needing the lower rate. All right. So with that question, another question can be asked of you: what conditions require a high mechanical rate? I think we already asked that question. So just make sure that you can answer that question as well too. So regardless of the metabolic alkalosis being there, know that the others require high rates. Okay. Right, PEEP. This next question is regarding PEEP or CPAP. What are some of the benefits of administering CPAP or PEEP?
Restores FRC.
Yes.
Improves oxygenation.
Yes.
Increases lung compliance.
Yes. Okay. What is the alveoli? What does it do to the alveoli?
It helps.
Maintains them open.
Keeps them open. Right.
Oh my gosh.
Keeps stable.
Shunting.
I heard shunting. What about shunting?
It decreases physiologic shunting.
Yes, it does. Yes. Yep. What about?
It increases it maintains a permeable, what is it, membrane, alveolar membrane?
Yes. Would you say that it closes surfactant depleted alveoli?
No.
Or excuse me, that's a benefit?
It closes?
Yeah, that surfactant depleted alveoli close. Would that be a benefit of PEEP or CPAP? So say no, because we don't ever want our alveoli.
We don't want it to we need them open. We don't want the surfactant to go
We
down.
don't ever want them closed. Yeah, we want them open. So that would be a no. But on the other ones, those are benefits, definite benefits, and reasons to add PEEP or CPAP. Bless you. Thank you. Oh, if you are using mechanical ventilation, which mode of, or which type, I won't say mode, so this is not a mode, it's a type of ventilation. Which type of ventilation can pleural pressure become positive during inspiration?
PPV.
I heard somebody say PPV, that is correct. Positive pressure ventilation. All right, now what do you, give me the definition for shunt. Valerie, what's the definition for shunt?
It doesn't respond to increased FiO2.
What doesn't respond to increased FiO2? So yeah, you're in there. So just tell me what. Tell me what specifically. What are we talking about?
Sorry. My phone's angry.
So you said it doesn't respond. So what's it? Tell me what it is. What doesn't respond? And how do you know it's not responding to increased FiO2? And tell me how much FiO2. What are we talking about? Now, was that Drika who was helping out? Were you saying something, Drika, earlier?
Yeah, I probably should say no, but yeah, it was me.
What'd you say?
You asked her what, and I was saying alveoli of the lungs.
Okay, all right. So the alveoli, okay. What else? Now, if we're looking at a blood gas, what are we looking at that's saying it's not responding?
50-50 rule.
Ventilation to perfusion.
Ventilation.
PaO2.
Perfusion ratio.
On the blood gas?
On the PaO2.
Yes.
PaO2, yeah. So we're looking at the arterial O2. So that's our goal. Our goal is to increase that arterial O2. So when we increase the FiO2, the arterial O2 should go up as well. But when we draw that blood gas, we see that it's not increasing, right? So now we're going to suspect a shunt. And the rule is that 50-50 rule, right? And we're talking PaO2 and FiO2. So if you're giving your patient at least 50% FiO2 or more, and your PaO2 is less than 50, then you know, or you have a good idea that they're shunting. Okay, so we're talking PaO2 and FiO2. So that would be your definition for shunting when you have a lack of response in PaO2 to FiO2 with patients receiving positive pressure ventilation. Okay. All right, so tell me about mean airway pressure. Mean airway pressure. Mean airway pressure is considered to be what? What's the definition for mean airway pressure? Not mean arterial pressure, mean airway pressure. What's the definition for that? We did the formula, so now what is it?
Mean airway pressure.
Average pressure across the total cycle time.
Okay. Yes. So you're looking. It's the average, and if you're really, being specific, it's that peak airway pressure. So you're looking at your peak airway pressures. Your mean airway pressure is the average of your peak airway pressure. So peak airway pressure, when you get that PIP, you're looking at a one-time deal during that breath. Mean airway pressure, you're talking about the average of multiple PIPs. Okay, so mean airway pressure, you're talking about multiple breaths, and now the ventilator is getting the average of all of those. All right, so now let's talk about what can increase your MAP. What are some things that can increase your mean airway pressure? Can your, if you increase your rate of breathing, can that increase your MAP?
Yes.
Yes, it can. It can. If you increase your I time, will that increase your MAP?
Yes.
Yes. If you increase your tidal volume, will that increase your MAP? Say yes, because if you increase your I time, that increases your volume, right? Which increases your pressure, which increases your MAP. So yes to that. What about PEEP? If I increase my PEEP level, would that increase my MAP?
Yes.
Yes.
Yeah.
Yeah, it's pressure. Yeah, it's pressure. So that lends to the total airway pressure. So yes. What about my FiO2? If I increase my FiO2, will that increase my MAP?
Yes.
I hear a yes.
Yes.
I hear two yeses.
I say no.
I hear a no. All right. What about the rest of you?
Yeah, I don't think.
So yes
I don't think so. No.
or no? Okay. So no. So I'm hearing some no's. Mallory, yes or no? Will FiO2 increase your MAP?
I'm gonna say no.
Okay. All right. Nicole?
I'm gonna say no as well.
Y'all don't sound too sure about the answer. So the no's have it. So increasing your FiO2 is not going to increase your MAP. Okay, so anything that would increase volume, anything that would increase the I time, anything that would increase the pressure, the rate, those things like that would increase your PIP, which means that would increase your MAP. Okay, so FiO2 does not increase your volume, nor your pressure, nor your MAP. Okay.
Sorry, you said volume, pressure, I time, and
volume, I time, your rate, your respiratory rate, anything that would lend to increasing the pressure.
right.
All right, so true or false, this has to do with positive pressure ventilation in general. During inspiration, pressure in the alveoli increases. True or false?
Excuse me, during positive pressure? Can you repeat that? I'm sorry.
Yeah, during PPV, pressure in the alveoli increases. True or false? That would be true. The pressure gradients of normal breathing are reversed. True or false?
Yes. True.
That is true. During your I time or during inspiration, alveolar pressure exceeds pleural pressure. True or false? During inspiration, alveolar pressure exceeds pleural pressure. That is true. Yes. During inspiration, pleural pressure decreases. True or false?
False.
That is false because we just said earlier that it increases. So yes, so that is false. Pleural pressure does not decrease during inspiration, it increases. Right, very good. All right, okay, so during inspiration, what type of ventilation causes an increase in alveolar pressure?
PPV.
Yeah, PPV.
All right, I heard PPV. I was going to repeat that. So what type of ventilation during inspiration causes alveolar expansion to increase?
PPV.
Yeah, PPV.
Okay, all right, that is positive pressure ventilation, correct. Okay, all right, true or false, and this is regarding negative pressure ventilation, so NPV, true or false? Negative pressure ventilation decreases pressure at the body surface.
True.
True.
That is true. True or false for NPV, expiration during NPV is passive, by passive recoil.
True.
True.
That is true. NPV is similar to spontaneous breathing.
True.
NPV is zero during at the mouth, at the airway or at the mouth. That is all true. All right. What type of ventilation causes alveolar expansion to decrease in pleural pressure? What type of ventilation causes alveolar expansion to decrease in pleural pressure?
NPV.
Circulation.
What was that?
NPV and spontaneous.
Negative pressure and spontaneous, correct. Negative pressure ventilation and spontaneous ventilation, correct. All right, okay. Describe preload. Preload. Would preload be considered the filling volume of the left ventricle? No. Okay, that is correct. That is not preload.
It's on the right side.
Mm-hmm.
Right ventricle.
Okay. Would preload be the difference between the end systolic and the end diastolic volumes? Difference between the end systolic and end diastolic volumes? Would that be preload?
No.
That would be more stroke volume there. Would preload be considered the stretch on the ventricular muscle fibers before contraction?
Yes.
Yes. Okay, so yes, that would be preload. Correct. All right, so make sure you know the normal values for bradycardia, tachycardia, your normal values for respiratory rate. So I'm not going to go into that because I think you guys know those values already. All right. And we mentioned stroke volume. I think we did stroke volume already. So with stroke volume, know that the preload, afterload, contractility, those things have a direct effect on stroke volume. The heart rate does not. Not a direct effect. It has an indirect effect, not a All right, so finish this statement. Complete this statement. The greater the stretch, or the preload, on the resting ventricle, the greater the blank. The greater the stretch, or the preload, on the resting ventricle, the greater the blank.
The strength of contraction.
Yes, absolutely. The greater the contraction. Very good. That's Starling's law, right? Yeah. The greater the stretch, the further out the heart can pump blood, the further out you stretch that rubber band and flick it to somebody that's in the next chair over there. All right. What's the formula for cardiac index?
Cardiac
Is your
output divided by BSA.
Divided by BSA.
I heard BSA.
Cardiac
Cardiac
output
output divided by
Cardiac output.
divided by
Cardiac output
Divided by
PSA. Yes, correct. Tell me again, what is the definition for CI?
Measures the
Is
work.
your cardiac index, cardiac output corrected?
Is
What's
it
that?
is a flow output?
Yeah.
Blow
The
out.
difference in body size,
The cardiac output
Yeah.
index to a patient's body surface area.
Now that's the formula, so I want to know the definition. So what is cardiac index? So if I ask you, what is it? Why are we calculating it? Why are we trying to figure out how much it is? Well, what's that definition that we went over the other day?
it's like me trying to find the difference in the patients, like the difference in the body size, like their
The cardiac output.
cardiac, yeah,
Differences
the
in
cardiac
body size.
No, not exactly. That's that old lady response. Not exactly. All right, so it is a standardized measurement of cardiac output in different sizes for different individuals. The value of cardiac output is going to vary per person. So by using the cardiac index, you now have a standardized measurement to use with everyone. Okay, so remember, the cardiac output, we have that normal value, but still it varies. But if you do the cardiac index, now you have a standardized measurement that you can use with everyone. Okay, it's just like your stroke volume index as well, same thing there too. You now have a standardized measurement to use with everyone. Okay. Alrighty. Also, let's do normal values. See it. Okay. What is your normal value, normal range for the pulmonary artery diastolic pressure? And we'll use this from Egan. Not from Cark. What's the normal range for pulmonary artery diastolic pressure?
Okay, with 10.
I said 8. Who said 8?
I said 5 to 15.
Egan says 5 to 15. What does Cart say?
8. I think it says 8 to 15.
8 to 15. Yes, so 8 to 15. Egan may say 5 to 15. Just remember your value there. You're good to go there. What about?
Are you using 8 to 15 or?
They're very close, either one. So you're not going to have a value that's going to be, in between there asking which one is the correct one. So 8 to 15 is what Park says. 5 to 15 is what Egan says on your test. There's no way you can miss this answer because one says 0 to something, the other one says 30 something to something, so unless you really don't know what it is, you can't miss this answer. So either way, if you said 5 to 15, you're still in the range of 8 to 15, right? So yeah, good to go. What about, let's go to CVP. What's the normal value for CVP?
2 to 6.
2 to 6 millimeters of mercury, correct.
yeah,
What about your wedge pressure?
6 to
6 to 12.
6 to 12, and here's another value that can vary based on what book. I think Egan says something slightly different, but still, as long as you're in that same range or similar range, I think Egan says 4 to 12.
4 to 12.
Egan's
Yeah.
4 to 12. Yeah. So still same range. You're not going to be asked something that's way different from either one of those. So you'll still be in that same area as long as you know 6 to 12, 4 to 12. Just don't say 25 to 30, something like that. That's way off from the value. All right, so what about the normal range for the pulmonary artery systolic pressure?
20 to 30. 15 to 30, 20 to 30.
All right, so 15 to 30. And I believe that, that's in CARC, 15 to 30. Somebody said 20 to 30? Some of your other references may say 20 to 30, but 15 to 30 from CARC is what we're going to go with, since CARC has been our major book of reference. So we'll stick with CARC for this, but 20 to 30 is not wrong. It's just, again, one of those that. All right. All right, so what about, that's fine. That one's good. How long can you allow a balloon to stay inflated to get the wedge pressure?
No more than 5 seconds?
No, well, 5 to 10, not more than that. So you shouldn't go 30, you shouldn't even leave it wedged. Okay, so just a matter of seconds, get your wedge pressure, deflate the cuff. You don't have to remove the catheter or pull the catheter back. You just have to deflate the cuff. Okay. Okay, what's the formula for mean arterial pressure?
The diastolic right 2 plus systolic divided by 3.
Right. So systolic plus parentheses 2 times diastolic divided by 3. Right. So you do that, and if you like that, stick with that one. There is a second one. You can use the pulse pressure formula, but stick with that one if that's the one that you've already learned. Stick with that one. All right. Okay. We're done. We are done. Questions?
Are there fill in the blank questions that we have to write in on the test?
Not to my knowledge, no. This is all Scantron.
Oh, okay, true.
All Scantron. Thank goodness, because this is a 100-question test. I'm not trying to hand grade a 100-question test. Right? No. Now that means it will take longer to get your results back as well. All right. Questions. So study your study guides, definitely your hemodynamics, ventilation, some of your modes of ventilation, your normal values there as well, and you should be fine. All right, so you guys also should have already seen that you are set up on campus. Y'all hear me?
Yeah.
Okay, so you guys are set up in Canvas to do your peer reviews, okay?